All right, we are moving seamlessly into the next panel. We've set the groundwork with a lot of storytelling, and now we're going to move more into the research implications of working in tribal communities. So honored to have such a high caliber panel of Indigenous researchers and thought leaders with us. So I'm going to pass it over to Cassandra, who will beautifully moderate this panel. Thank you.
I'm going to try my best. Can everybody hear me okay? Okay, great. So my name is Cassandra Nguyen. I am an assistant professor of cooperative extension at the University of California, Davis. And what that means in practice is that I am a researcher, but I'm also a researcher that's focused on outreach and extension and ensuring that the knowledge that we gather with our scientific studies actually makes its way to the community, but also that the knowledge in the communities makes its way into kind of research. And so I wanted to start our session briefly with just some introductions. So I'll introduce myself and a little bit about my background. And as I mentioned, my name is Cassandra Nguyen, but that's actually a recent change. So previously I was Cassandra Nicolaus. That is a name from my father, who is a German immigrant. But I was raised by my mother, and her family all grew up in Washington State, though was originally from Europe. And what I'm saying there, without saying it directly, is that I'm white. I'm not Native. And so I'm very lucky to be in this space and work in this area. And it's really only by the grace of the women who are Native, who have been serving as really incredible mentors and have invited me to work with them in research projects, but also the incredible Native women that I work alongside in the projects as colleagues, which I'm really excited to share the stage with today. And so as not only a good moderator, but also a good white ally, I'm gonna be quiet and I'm gonna let my Native colleagues introduce themselves, and they're gonna really be leading a lot of the content for today's panel. And I'm going to ask Kelli if you want to start us off by introducing yourself.
Hi, good morning. My name is Kelli Wilson Begay, and I come from the Kickapoo tribe of Oklahoma. I'm also Seminole and Muskogee Creek, and I am a registered dietitian by training, but run my own firm now and consulting and do lots of work in nutrition, public health, and really anything with Native communities, and being a good relative, a good ancestor, and an advocate on behalf of my community.
All right. Okay. Yat a bene Bennally initiate Twitch in initially Sitnajini Pashichin Klane Dashachedo Kiani Dashanale Yatahe de Nashak Seattle, Washington de Kesht Akut out the nest on the How many of you all been to New Mexico? Woo! All right. Hi, everyone. If that didn't give it away, I said good morning, so maybe try it with me. Yat a bene. Right on. You better remember that when you go to New Mexico. But they'll laugh at you if you say it in the evening, so only say it in the morning. Okay, that's good. That's good laughter. All right. So my name is Bennally. I use the pronoun she, her. I'm originally from New Mexico, so I grew up on the Navajo reservation, but I'm also White Mountain Apache on my dad's side, which would explain why I'm so tall. Usually our Navajos, my grandma is 5 feet. She's literally like right below my shoulder, but I'm 5'10". But that's not why I came here today. I actually live in Seattle, Washington, where I got my master's in public health at the University of Washington. Go Dogs. I don't know if anyone followed football. That was so sad, but we had a really good run. It was like the first in history, and everyone was really excited about it. But anyway, I work there at Seven Directions. We're a tribal public health institute. We're housed under University of Washington School of Medicine. We are completely separate from them. We do a lot of research in tribal communities. We're a nationwide organization, and there I'm a research coordinator. So I'm really excited to work with them, but even more excited to be here with my colleagues, because what we'll be talking about later today has nothing to do with UW, but I just like to throw in Go Dogs every now and then. All right, I'm gonna hand it back over to Cassandra.
Okay, Great. So now that we kind of have shared a little bit about who we are and what perspectives we bring, the structure for the panel is that we're going to have a brief presentation from Kelli and then a brief presentation from T. We'll then have a collaborative kind of discussion and presentation about some work that we've done together, all three of us, and then we'll have some opportunity for discussion. Both structured as well as with the larger audience and also feedback. So Kelli, with that, I'm going to hand it over to you and also hand you the clicker.
Oh, thank you. All right. Okay, can you guys hear me? Awesome. Okay, so we're just going to get right into it because there is a lot that we want to talk about and share with you, and we also want to hear from you. All right, so I'm so glad that we had this foundation setting earlier today with treaties, talking about treaties, with talking about the land we're on now, our tribes here locally, but just to give you kind of this broader perspective, there are 574 federally recognized tribal nations throughout 37 states. There are more state-recognized tribes as well that are not included in the 574. So for those of you who aren't quite familiar with how many tribes and how many different unique strong communities are out there, this kind of gives you a little bit of a perspective as far as what we're all talking about, especially when we talk about all of the unique situations that are in every single tribe. All right. I did want to mention that my tribal affiliation, I'm an enrolled member of the Kickapoo Tribe of Oklahoma. You all have heard that there's also a Kickapoo tribe in Kansas. There's also a band in Eagle Pass, Texas. And really just to kind of give you an idea of, I mean, I'm not like an anthropologist, I'm not a historian, but our Kickapoos originally were Woodlands people. We were in the Illinois area. Once we were relocated, forcibly relocated, different groups of Kickapoos went to different areas, which is why we're spread out throughout, the South West. So just to give you a little bit of background on that. Are there any other Kickapoos in the audience? Okay, yay, all right. My auntie grandma and my other auntie. All right. Oh,
Yeah.
you know what? I did not. I'm sorry, I'm trying to do too many things. I didn't practice my button clicking.
I can advance the slide for you if that's easier.
Okay, you know what? And I need to, sorry, 1 second. I need to, I think I'm allergic to IT as well. It runs in the. But, okay, I think I'm back online now. Okay, next slide. All right, so we also heard about the different kinds of health systems that are in Indian country and that serve Native people. You heard of IHS, that's the federal side of health system that the government provides access to care based off of treaties and obligations to provide health care for Native people. So you have the IHS, the feds, right? Then you have the tribal health system. These are tribally operated healthcare services, like the Iowa tribe talked about their health system, working with Nebraska. Was it CAW? Sac-and-Fox. Oh, Sac-and-Fox. So those are like tribal healthcare services that are a little bit different. They don't fall under the same purview of a federal system, which is wonderful because the tribes are making decisions for themselves and providing the care and resources that they need based off of their communities, not being forced or told by federal funds and government what they can and can't do necessarily. I mean, there are some stipulations, but anyways. The other is urban. So we had our San Diego urban colleague talk about that system. So that's, again, a whole nother system. We know that 70% of Native people live in urban areas. So this is huge. This is very important. We know that our tribes and reservation settings are important, but a lot of those tribal members are going into the cities or are going to urban areas to work. They also live in their homeland, their homelands of their reservation. So there's a lot of back and forth. And urban clinics and urban programs are so important. Like our colleague mentioned, there's over 100 tribes represented in the urban clinic in San Diego, and that's pretty, common with other urban facilities that are throughout the country. Next slide. Okay, so I'm just going to share a little bit about some of the work I do or the work I've done. We know that food is medicine is not a new concept among Native people. Our connection to land has always been a core tenet of our culture and for survival. These couple of projects that I'm going to just mention, one is the What Can I Eat? Diabetes Nutrition Education Program that's created by the American Diabetes Association. What my colleagues and thought partners did, and it was actually also in conjunction with the Mdewakanton Sioux community, the Shakopee Mdewakanton Sioux, wanted to invest in making this What Can I Eat? Diabetes education program tailored to the Native community. And what was so great about this is that the people behind this project, and I wasn't involved at the beginning, but the people behind the project knew how important it was to partner with people who are from the community. That is one thing that I've heard, and I'm so uplifted by the work that's being done locally just by getting Grandma Auntie, in as a staff member. And that is huge. That should be the gold standard. Any program that's working in tribal communities needs to have a Native person who understands the community on their staff. And they need to be paid well. I one time saw a shirt that said, "Pay me like a white man." And the thing is, because our community members, we will do it for free. We will do it because, like Jason said, we're not doing it for the money. Mm-hmm. But I also know that people in our communities are taking care of their community, meaning their family, their extended family, their mothers, their grandfather, they're taking care more than just themselves. And so, so anyway, they need to be taken care of as well, because what they're sharing, their lived experience, is worth so much more than you could probably ever pay them, honestly. So for those of you who do run these programs and who are just keep that in mind. I'm going to be an auntie. Oh, I'm an auntie, but I'm going to be a grandma. Not really but I'll be like the grandma who's going to get on to everyone if you don't. The other is the Prevent T2 curriculum for the CDC National Diabetes Prevention Program. So I'm fortunate enough to be able to work with that team who is adapting it for Native communities. And it's not done. It won't be done for maybe the end of this year. But things that we're trying to work into this are like traditional foods by region. We know that traditional foods is not specific even to a tribe necessarily. It's usually regional because, just like has already been mentioned, our people, there were no land lots, there were no division of states. We all took care of each other. We were all in the same region. And so our foods are really regionally based. So we're trying to work this into this new curriculum that's tailored for Native communities. The other part of this is that, Jason mentioned, or actually I think others mentioned too, about the commodity foods. And those are the same thing. For those of you who don't know, that the slang commodity foods is the food distribution program on Indian reservations, or FDIPR. And even though those, they're trying, and they're getting better, but those foods are common foods in our communities. Those foods still have to be talked about. Those foods still have to have nutrition education around, because they're in our communities and people are using them and they know them and they've had them for generations. So just, being mindful of that. So we're working that into this curriculum as well. So these are things to be on the lookout for. The What Can I Eat program is already available, and it's through the American Diabetes Association website, and it's free of charge, which the PI on that project was adamant. Her name was Kelli Moore, Dr. Kelli Moore. She's retired now, but she was adamant that this curriculum be free of charge to Native communities. She did not want ADA making money off of this, and so for those of you who are working in the diabetes education space, you need to check it out. And I wish I had more time to talk about that, but I don't. Oh, next slide. Thank you. So I kind of mentioned some of these already. Adapting these nutrition programs to Native audiences. Like I said, we're all very different, urban versus rural. Traditional foods should be included. Also, there's things like the foods found in the FDIPR program. We know how food is important in social gatherings and celebrations. And then also that the community-based education approach really works the best. I will say another thing related to these nutrition programs and curriculum is that the imagery should look like us. We want to see us in this curriculum, right? And culturally tailoring a curriculum is not just the images, so I want to make that clear. But also, if you are trying to be a good ally, find original photography, hire a photographer who works in Native communities to get the imagery, because the stock photos, I'm so tired of seeing this one lady that I'm like, oh God, here she is again. She's like in everything, she gets around. She's in diabetes, she's in nutrition, she's in, I don't know, but like all these different things. So again, hire your Native photographer who can do imagery just for whatever project you're working on. Not all brown people are Native. There's another kind of thing that I've seen recently is there's a lot of our Central American relatives who are showing up in our American Indian curriculum, and it's like, that's not us. Like, we can tell, and that's not us. And we all look different. So that's the other thing. So sorry, that's a big challenge, I know. But anyways, yeah, I needed to say that. I feel like I guess there's a lot of things I needed to say I didn't realize. Next slide. So related to food as medicine in tribal communities, I'm really fortunate to be involved in the IHS brand new produce prescription pilot program. And there are 5 sites throughout the country. This project just started in July, so they're about halfway through their first year. It's a 5-year grant project. They get $500,000 a year, which is a lot. And it's wonderful and it's amazing. Like we heard earlier, having a time limit of like a year to like pilot, implement, evaluate, report is crazy. So we're so lucky that this is 5 years. There are programs who have taken the first year just to get established. I mean, they didn't know they were going to get this money, right? Like you apply for it, you don't have your team. Maybe a lot of these have never done a produce prescription program in their communities, and so they're having to do a lot of groundwork in this first year. However, I will say that there are programs, and which is something that is common in Indian country, is you do a lot with very little resources. And so there are programs who have a staff of 2 who have already started this pilot project, and they're doing amazing. They're learning a lot of lessons, and they're teaching the other grantees as they kind of go along. But we're really fortunate to be able to be in such close contact with these grantees because, again, just like Ms. D was stating earlier, our data is the stories, right? Like it is, we're working with these grantees. We're trying to capture every little thing that they're mentioning as far as what challenges they're running into, what changes they've had to make already, where they want to go in the next year. I mean, these are things that it's, again, evaluation, and, it's our jobs to be able to tell it in the right way. And so, again, these are programs. I'm so glad to be a part of this project, and I hope to be able to share more, as we go along. These projects are all doing different things. Some of them are clinic-based, some of them are community-based. They're all tribal, so there's no IHS, and there's no urban, so they're all tribal facilities. So they're again, like I said, doing different things. Their approaches are very different. Some are working, heavily with their clinic staff and their providers. Some are doing more outreach in the community. And really excited about one who's working with Indigenous farmers and looking at it a whole different way. So we're just super excited about, what this project will tell us and what we'll learn from it. And hopefully we can scale it, across more tribal communities. Next slide. I really don't know what my time is, sorry. But this is the last one. So just, thinking about indigenizing approaches for improving food and nutrition security, like what has been said already, honoring our ancestors and traditions, working closely with community from the very beginning, hiring the auntie grandma, uplifting and supporting tribal food sovereignty. Sometimes that's an area of work that people aren't quite familiar with and they don't know how to help, but ask and support it in any way you can, because the people who are doing it know exactly what they're doing and they're doing it the right way. And so trust them. If you're a funder, give unrestricted funding. Unrestricted funding goes a long way. Just like our SNAP Ed folks, I'm also working on a SNAP Ed project in Colorado, and that's the biggest thing. They want to serve a meal. They want to feed their community and feed their people and show them how this really looks in real life on their plates. But SNAP Ed won't allow them. They say a sampling. And our people are like, what? That's crazy. So anyway, and creating safe spaces and being mindful of the power dynamics. If you are a funder and you're trying to work with community, I know that can be hard too, but being really mindful of that, finding that champion in your community. If there's an elder who maybe comes to your programming or what have you, really get to know them. They can be the biggest influencer that you've ever known about, and they can make a lot of things happen that you would never be able to make happen. And lastly, trust communities and that they know how best to serve their people. Okay, that's it. Awesome.
Why do they always schedule us to go after really good presentations? Just kidding. Okay. If you're a native, we like to joke. If we're not joking with you, we don't like you. Okay. You've been feeding me all weekend, so I really like you. All right. Hi, everyone. I'm T, if you already forgot that, T for tall. But I'm going to be leading you through what we have at Seven Directions, which is an Indigenous evaluation approach. I have it in my hand, actually, and I actually want to show it to you because it's really beautiful. Kelly was making fun of my really big suitcase this morning, and Kelly, it's because I had all these toolkits. But anyway, it's an actionable guide for organizations serving American Indian and Alaska Natives communities through opioid prevention program planning. Don't get too caught up on the opioid prevention program planning. That's just like a large grant that funds our center, but it can be used in a variety of settings, such as the one we're in today. So take out your phones, and I won't be mad if you're on your phone, but basically throw us a big follow on Instagram, Facebook, Twitter, and LinkedIn. That is my millennial side coming through. I met a lot of people that said, I don't use social media, so let's use it together, and while I'm talking, you can follow us. But basically, Seven Directions, we're one of three. We're the first tribal public health institute. We are under the National Network of Public Health Institute, if you're familiar with that. Our other sites well, not our sites, but the other Public Health Institute sites that were set up were at North Dakota State University and most recently at the University of New Mexico. So it's really exciting, hopefully we'll get more tribal public health institutes. But basically we're an organization, like I mentioned, at the University of Washington, and what we're trying to do is serve tribes nationwide. A lot of it has to do around technical assistance, but such as evaluation, but some other things that I've been able to be a part of is like our Indigenous Public Health Leadership Program. I had the opportunity to share that with a few folks that I talked to yesterday, and it's really great because then we got to recruit emerging public health leaders nationwide, and so we picked tribal representation from literally every part of the United States. So I'm Navajo, and our tribe is the largest tribe, and usually you'll be in a room with like 10 Navajos and maybe one from Kickapoo. So if we have any representation. So we did a really good job at mapping it out, and we got representation from the East Coast, West Coast, and of course like the Midwest and Southwest, and we trained these leaders on everything from like grant writing, digital storytelling. We provided that networking just for people to share a meal, for people to interact. COVID made us really weird, and now we call our business cards that weird thing that we carry. And so we were able to provide opportunities like that for them to say, I don't know, visit the University of Washington. We provided them with a tour, maybe other opportunities to explore like higher education. But more specifically to the Pacific Northwest region. If you're like me and you're not really sure of what it is, I'm trying to help you envision this. So just think of Canada, and then along the coast, there's different coastal tribes. And from that, we conducted a research project called Canoe Journey, and we worked with different youth. And so Canoe Journey, just in a nutshell, because it helped me, because I was like, what is water? I'm from the Southwest, and what is a canoe? So what it is they go along the coast, and each family has a different canoe family, and within those families, they host each other during the summer, and they participate in things called protocols. So a lot of that's just like cultural traditions, teaching, songs, dances. And so we did a mixed method. So what we did was we collected surveys, interviews, and focus groups, and we talked to youth. We said, what do you think about Canoe Journey? And so from that, we're doing an analysis, and the hope is that we'll see that Canoe Journey is set up as a protective factor for Native youth in a sense of protecting them from stuff such as substance use. We're looking at things such as suicide prevention, mental health awareness, and things like that. So we're working really hard to get papers out of that. So if you take my contact down and follow us on Seven Directions, you'll be able to see a lot of cool content that we're producing. I'm sorry I'm talking so fast, but I really got to get us through this presentation. But I would love to talk about Seven Directions all day. I have brochures if you just want to take that back. There's a long ride to the airport, so you could take your time looking at that. Or you could just share it with, you could prove that you came here and you'd be like, I got this really cool brochure. And then also I have these toolkits. So I'm gonna move on to the next slide. Actually, I was talking this entire time, sorry. I'm like, follow us. I'll give that 10 seconds. I'm sorry, I should have let you know, my bad, okay. All right, an acknowledgement. And so before I go into like this really great toolkit, I just want to emphasize what's been said from earlier's panel and then also what Kelly had mentioned. Sorry, back to the acknowledgement page. Let's see. Yes. leave it there for just a moment, please. So here, this work is honestly not just the work of Seven Directions. A lot of it was led by a framework that was already established from a researcher called Dr. Joan LaFrance, and they did in collaboration with the American Indian Higher Education Consortium. They created this framework already, and so Seven Directions was able to adapt it in addition to tagging in their opioid technical advisory group and create this really great Indigenous evaluation approach. And so from these advisory group, they're representative across, like I said, the US, a lot of them in leadership positions or just like tribal representation. And then of course we have a really great group on the top. This past summer, we had our own conference, which was out in Prior Lake, Minnesota. So we were on Shakopee territory, and there we were able to bring people from all over. Believe it or not, we gave as a token of gratitude to our participants, we did 300 beaded lanyards. Can you believe that? I know. My fingers were so tired. I even got my family in. I had a little sweatshop going. It was crazy. But everyone was really appreciative of it, and we're looking forward to our next conference next year. So just, keep Seven Directions in mind as far as like attending a conference like that. And so our team is representative of different tribes, such as myself. We have people, our director, she's from Mandan Hidatsa tribe, but also we have really great researchers from like our relatives in Nepal. So we have like a very diverse background of researchers, and also some allies who just want to do like really great work with tribal communities, but also learn like what it might look like. So on the next slide, I'm going to read this verbatim, but basically what it says, for those who can't really see in the back, is that this toolkit is dedicated to the Indigenous ancestors and Indigenous communities whose knowledge and traditions have supported the health and well-being of Indigenous people since time immemorial. We hope this toolkit will uphold these strengths and promote the imperative need for Indigenous evaluation approaches in health promotion and prevention programming. So I wanted to note that just because, this was done not only with like checking the box to our funders, but also with the intention in mind that we're being a good relative, we're being a good ancestor, and it's been said before, but this is like a nice tangible evidence that we're trying to do that, especially in academia. So on the next slide, I'll be talking about what an Indigenous evaluation approach. I'm going through this super quickly, but I'll let you know how you can get the more in-depth minus the joke. So I don't know, it's up to you if you want to look it up. Okay, so Indigenous communities, as mentioned already before, have been disproportionately impacted by historical trauma, continued structural inequities, including harmful social determinants of health and negative public health outcomes. So if you think about that, it's like, okay, so what could we do in response to addressing these? And that's thinking about culturally grounded programming, which also requires culturally grounded evaluation approaches. And what that would look like is supporting the ancestral and cultural wisdom of our elders, of our community members, and its representative of the community that you're working with or collaborating with. And so the next one, on our next slide, it'll go over like what is an Indigenous evaluation. So I'm going to broadly talk about it, but it'll be on the screen for you to read and kind of digest about what I'm talking about. So an Indigenous evaluation refers to the use of Indigenous ways of knowing and community involvement when assessing or evaluating efforts' effectiveness or a community impact. I think another great aspect of Indigenous evaluation approach is that it can be used, as I mentioned, in any type of public health prevention program, such as addressing food insecurity or food sovereignty among tribal communities. So when you're thinking about if you want to partner, because we have this opportunity to accept tribal serving organizations or tribal communities as far as like partnering with us to provide this Indigenous evaluation approach. So on the next slide, before I even try to sell you on this, it's looking at what's the difference maybe between Western and Indigenous evaluation. So looking at the top, both of them are basically the systematic gathering of information about the community, service needs, and outcomes. I won't spend too much time on the Western because I'm pretty sure if you've gone to grad school, you've gone on undergrad, or even we're in this setting today, we know what that Westernized evaluation looks like. I think just pointing out that it's a very rigid and restricted definition of what data or an evaluator role is. And oftentimes, it was already mentioned earlier, you're not sure where that data is owned or who it's going to or who's using it. And so for shifting gears to the other side, which is an Indigenous approach, it's emphasis on a holistic knowledge and types and very broad type of data. And so that data can involve like community, people, as mentioned earlier, storytelling. There's community-defined questions. There's an emphasis on the local relevance. Like we come in with questions, we're like, we think this is really important, and like we want to know this, and the community's like, no, we don't want to know that. We already know the answer to that. Instead, we want to do this instead. And so really being flexible and accommodating and just working with the tribes. It's also in deep involvement and ownership and the capacity building of decolonizing data and the stewardship of it. So what is that? It's data sovereignty and the governance of data. The tribe owns the data. The tribe's gonna do what they want with the data. If midway the tribe's like, you know what, I don't want you part of it and we're taking our data away, that's giving them that, that autonomy to do that. And so I'll move on to the next slide, and I'm just trying to speak very quickly, I'm so sorry. But if you're thinking about further examples of what Indigenous evaluation are, I'm not gonna read every one of them, but you can read it on your own. And honestly, the ones that I point out is like using cultural based storytelling and biometric data to describe our prevention's program journey and purpose. Maybe it's like we have what was mentioned earlier, such as like harvesting Indigenous foods at environmentally sustainable times to reduce things such as diabetes. And then at the bottom, which is like you should take home with this if you forget everything that I said today, it's just remember using a community advisory board for an iterative feedback and providing them with monetary compensation and culturally respectful gifts. And if you don't know what that is, just ask. But oftentimes you'll have an anti-grandma, as I heard, throw around, and and when you have those staff that are representative on your team, they'll know what to give, and it'll be the good gifts. Okay, so if we go on to the next slide, this is just to show you like, okay, what our framework looks like. As I mentioned, we adapted it, but I think the main thing to take away without me going through every step is to look at the middle, and that's the community goal, and that's keeping it in mind. Like, what is this goal? What are we trying to do, and how will we work together? And so what you'll notice is that it's a cyclical learning process, and what that means is that evaluation is interwoven with the program design and implementation, and this process can go round and round, or start back at the beginning or start back at the middle, and I think that's really like a great thing about this type of framework, and so just keep that in mind. Okay, so getting to the end, but basically, like I mentioned, I have a couple of these if you want to take it home with you. It's kind of heavy, but it's really pretty for you to look at. But if you're just like, no, I just want to like keep my luggage light, you can go to our 7 Directions website where you can get that for free. It's a step-by-step guidance. They include worksheets and concrete examples, and even more exciting, if you go to the next slide, is that you can stay in contact with me. There's my information, but if you want to do me a really big favor and take out your phones again and just go to the QR code, like if you're going to a restaurant or wherever you go and they tell you scan the menu, that's kind of what I'm asking you to do. You can keep it on your phone or not, and if you're interested in partnering with 7 Directions for this free training, it's going to be a lot more in-depth, a lot more people on our team, and we're able to meet you where you're at. You can use that form, or you could just write, T was awesome, she did great. She's amazing, she was tall, and she had the best jokes in the house. You could do any of those, but that'll wrap up, and I'll toss it over to Cassandra to lead us through the next part of our panel. Thank you.
I like to control my slides. So the next part of our panel is going to be focused on a specific project that we just so happen to all 3 work on. And it's going to be kind of illustrative of what we've talked about today as we think about what implementation and evaluation might look like in the context of food is medicine or food as medicine. And so when we put this together, we thought about what kind of presentation we wanted to give, and that it wouldn't be your typical kind of oral presentation at the national conference, and I'm going to show you some p-values and some graphs, and you're going to be really impressed. Instead, I think we tried to take a more of a story approach, which is not a natural kind of tendency for me, and I'm definitely leaning on my colleagues as we think about communicating this experience in a way that I definitely wasn't trained in grad school. And so we'll talk about kind of what brought us together, a little bit about our results, and some of our reflections and thoughts. And so when we think about the planning phase, we really think about the people that came together. And this whole project really started with a conversation, as I'm sure many people that have experience with various projects can attest to, where myself and Lydia Kim, who's pictured here, who was at Northern Navajo Medical Center, which is based in Shiprock, New Mexico, we're having a conversation about food security, and we were talking about the hunger vital sign, which many of you may be familiar with, and we'll show you exactly what that is later in the presentation. But she said, as a provider, that she felt that people weren't always comfortable when you're asking questions about whether you're worried about food and about the consequences if you answer that question in a way that would indicate food insecurity. And so when we talked about, is there something else that we could do? I said, not that I'm aware of, but we can try. And so we wanted to see if there was a way that we could ask about food security without focusing on the kind of deficits that we think of when we think of food insecurity. And so the individuals listed here were really local to this area in New Mexico, and includes the incredible Kelli Wilson Begay, who was able to collaborate on this project, who got involved in addition to our team based in Washington, as well as additions that came along, like JoJo, who's on the far right here, as the project progressed. We also, I think, had a really short timeline. I think it was a year or 18 months. And even in that short timeline, there's turnover and changes, and the biggest thing that we had to learn was to kind of pitch in, ask for help when we could, and see who was around that was able to assist. And so it was really incredibly valuable that we were able to have people on the ground there locally, as well as the team in Washington State, where we were able to work with Dr. Amanda Fretz, who is an assistant professor at University of Washington, who was able to provide funding. We have T, who has lived experience and knowledge around coordination. Myself, that brings kind of the data nerd side of things. And then Kelli, who's actually able to talk to people and have a conversation and is less focused on kind of numbers as I am. So this was our team. And so I'm actually going to pass it over to T to talk a little bit about the background and the approach that we took for the project.
Yeah, okay. So this was done on Navajo Nation, and these are just some quick fun facts for those who are not super familiar. As I mentioned, it's one of the largest tribes out there, covering New Mexico, Arizona, Utah, and parts of Colorado. It's also described as what you probably know as a food desert, and there's only 10 supermarkets across the Navajo Nation, and being a tribal member, that is very much true. Fun story, it's kind of astonishing right now because I live in Seattle, and right across the street is a Fred Meyer's, or a grocery store, and it's fully functional. My little cousin, who still lives on the reservation, visited me over the summer, and she went back after, back to school, and her teacher said, Colby, I heard you went to Seattle. What was your favorite part? We did so many fun things. We went to the Space Needle, we went to the water. She said, I went to Fred Meyer's. And they were like, what's a Fred Meyer's? She's like, who is that? And she goes, it's like a Safeway, but my sister lives right across the street. And so she's 9 years old, gonna be 9 years old, and so just the look on her face, wow, you have access to food like that. It's a funny story, but also it's kind of disheartening because we grew up similarly. But on to food sources, a lot of it comes from gas stations, convenience stores, flea markets, trading posts. I never knew it was bad or I wasn't getting enough until I went to undergrad, until I got to bigger metropolitan areas. I was like, oh, there's other places to get food. And so I just wanted to share that background. And then also like why Northern Navajo Medical Center. I think a lot of it has to do because of the connection, of course, between Cassandra and Dr. Kim, but also it's one of the 5 federal service units in Navajo Nation. Kelli spoke about it just briefly as far as like the IHS umbrella, but Northern Navajo Medical Center is under that. But also there was an express concern about the current food insecurity screening procedure. It was a bit stigmatizing. If you're from a tribal community, you know, but what I've learned from my grandma, just because she's been in and out of dialysis, is that I had asked her, like, why didn't you like tell us you had diabetes? The entire time growing up, I didn't know she had diabetes. And it wasn't until later, until she was in kidney failure, and now she's getting treatment for it, is finally and in Navajo being her first language, we had a like real conversation, and she was like, I just didn't want you to worry about me. And that's just like not an uncommon story between that intergenerational, is that a lot of Navajo elders don't want to share like what's going on with them or what's happening, or they don't want to share income because they don't want you to think of them differently. But what we want, how could we tell them like these are not bad things, these are actually like opportunities to get access to different types of programming, but the food insecurity screening tool just wasn't doing that. And so just to give you an additional background, so instead this program, or this project, I'm sorry, developed an alternative screening. And so that's what we'll jump in right now briefly. And so what we did was, for those who were expecting a p-value, hopefully this will kind of help you as far as like, okay, what was the approach? What was the reasoning in addition to shaping this research project? And so what we did is we did an exploratory study, starting with our qualitative interviews. As mentioned earlier, Kelli did interviews at Northern Navajo Medical Center in collaboration with different staff. And what they were able to do is just get more information about like how they felt about the old food insecurity screening tool, and then also the new one. And from that sample, it was a convenient sample of 25, so not very much, but the conversation was so rich, and just the amount of time that was spent talking to these different elders there at the hospital. Because what we saw in the data too is that the population, you know, they've received IHS for most of their life. Most of my life, I was born in IHS, and I received care up until like I moved to Seattle, and actually was able to go to a different facility because I do have health insurance now. So just background on that. But also from this process, we were able to revise the instrument, which was our food insecurity screening tool. And so we're able to do these, and you can read this on your own. I'm just going through it briefly. But from that, we were able to develop this survey, and from that survey, we were able to get additional insight about like what the thoughts around were this alternative screening tool, and then an analysis was done by Cassandra. And so from that, we'll be able to share some results, but just to give you more information of how this was developed. So the previous screening tool, these were the questions. I'm not going to spend too much time on it. It's just asking the past year, how did you feel? What did you do? And so this was kind of interesting because I don't even remember what I had for breakfast yesterday. So then asking someone in the past year, what did you do? So you can tell it wasn't very insightful or informative for like how to help individuals. And so it was really great when I jumped onto this project because this team was already working with an artist that was from the Northern Navajo Medical Center. And so what they did is they were able to create these different pictures, and from these pictures, instead of asking, you'll see, well, I mean, there was also words associated as far as like what their plates look like. And so ranging from like mostly traditional foods that you'll see on 1 and all the way to 5, which is like convenience stores. And of course, where the hospital is located, there is access to a lot of different convenience stores and fast food stores, and so that's why we have that on there, or there's a mixture of the middle. But to give you an example of what some traditional foods that are present on Navajo Nation, we have our blue corn mush at the top. We have different like vegetables and forms of squash, and then also the primary types of meat that we eat in the households, like mutton or sheep, in forms of stew or however you decide to cook it. And then we had this and emojis, right? Like, how did you feel as far as like satisfaction with your food? And of course, that's kind of like self-explanatory, but we had the words there accompanying it. And then another question was asked, like the amount of food, and that was just based on like their serving plate, what they typically had. And so that was also added to the alternative screening tool. But to share more about like what did that look like? Did it actually work? I'm going to toss it to Cassandra and Kelly to talk more about that.
Yeah. Thank you. So Kelly's going to share with us, as T mentioned, the first step was the qualitative phase. And so Kelly will share with us a little bit about what people shared during these discussions.
Yeah. All right. So I was really glad to be able to talk with our community members and relatives. We were in a clinic setting, so just think of that, in an exam room, so think of that too. I mean, these are things, you're having to work with. Also, relationships are huge, right? And so trying to do an interview and ideally the plan was 15 minutes to do this. Was like, okay, 15 minutes was getting to know one another and like, where's your family from? Where did you grow up? How long so that was probably one lesson learned, was that we need more time to spend with people, especially in our Native communities when we're doing these kinds of things. But some of the things that were shared, many of the participants, oh, sorry, do I have the? Oh, you have it. Okay. So many had personal experience or knew people experiencing food insecurity. But I will say that it wasn't always like an apparent thing. It was like, well, they wouldn't say they didn't have enough, but they had family. They ate with their family or their neighbor, or they shared food. So I don't think it was like a very clear and easy response about being food insecure, because they were able to squeeze pennies and buy the food and make things work and be resourceful the best they knew how. The other is, the words in the existing hunger vital signs screener is a little bit confusing, especially some of the terms like often true, sometimes true. Those were hard to kind of process and what that really meant. And so that was a little bit hard to translate, basically. And then the word worrying, that got me worried from the money. So I think, again, there is another, like the thought process of how these questions are asked and how they are translating them into what it means to them is not an easy translation. And then just kind of the what they felt like when their providers wanted to talk about food insecurity or food security. A lot of times, they weren't always that sensitive, and they're usually, and in this setting, there are many providers who are non-native, and so bringing this up, I think people or patients felt more reserved in wanting to talk about that with this person, and so again, it depends on how it's asked as well. So they just thought it was kind of stressful.
So those were some of our qualitative insights, and we use that to adjust and update the alternative screener. And then what we did was we tried to do some quantitative comparisons to say, hey, we have this new screener, we've updated it to reflect the feedback that we received. Can it replace the old screener? And so we did find, when using the old screener, over 70% of the patients were responding as often true or sometimes true. So if you're familiar with the food security statistics, for the general population, it's about 1 in 10, 1 in 8, depending on the year. Over 70% in this particular sample, and this was just a convenience sample, so it may not generalize to the broader community, really just shows how widespread food insecurity is. However, to try to address this with this alternative screener, we found that there really wasn't a strong statistical relationship between their answers to the old questions and their answers to these new questions, which was disappointing that we couldn't have this immediate solution to say, oh yeah, you can replace these old questions with these new questions and you'll be just fine. And so in thinking about these results, I think that one of the things that might be happening is that we might just be tapping on completely different concepts, right? Food insecurity with its deficit-oriented kind of definitions, in contrast with a general pattern and acceptance and happiness with your kind of food, they may simply be different concepts. And however, this data was still really valuable. I think we learned a lot about the process. We also were able to show this data to the IHS practitioners to really show them concrete data about how widespread food insecurity issues were. And T actually led a grand rounds presentation with their providers, and it had a lot of engagement around what can we do? How do we better address this? And that was really reflected in the qualitative interviews as well, is they say, okay, what can you do about this? We know food insecurity is an issue. But ultimately, the question that I've been thinking about since being here is, do we need a screen for food insecurity for these programs? Do we need to ask these questions to decide who is going to receive a produce prescription or not? And deciding not only how to implement and evaluate programs that are in line with Indigenous perspectives and values and priorities, and in a respectful way. Does that include screening? Which was not the question I figured I'd be asking after finishing this project. And so that is everything that we wanted to share about this particular project, and also reflecting our gratitude for our collaborators. And with that, I want to be respectful of time and maybe just ask one question to both Kelly and T. But before I ask the question, I want to quickly survey the room. Of the folks that are here, how many would consider yourself like a funder or like, funding research or programs or outreach? Okay, just a few. And then how many would consider yourself a researcher, whether by choice or coincidence? Okay. And then how many would consider yourself to be involved with healthcare practice, implementation, systems? Oh, okay, great. So given the composition of the room, we were hoping to be able to kind of address what are the recommendations and considerations for each of those groups. But considering the vast majority of individuals align with being associated with healthcare implementation or practice or systems, I think that's the best place to ask the question of what would be your recommendations and considerations for folks that are interested in screening, implementation, evaluation. I'm going to toss it to T first, I think.
I'm gonna be honest, I thought you were gonna ask Kelly because this is her realm of expertise. But let's finish with a bang, so I'll get us started. I think recommendations moving forward, and it's kind of hard to say this, but it's also been like emphasized in the past panel, was there just needed to be more time. There was a lot of obstacles that we were able to get through, but it was really difficult in a sense that a lot of the burden fell on Kelli and our collaborators at Northern Navajo Medical Center, especially with traveling. The convenience sample, as you notice, is pretty small, and the tribe is very much larger than what we were able to collect. And I just think that yes, a lot of it has to do with funding, but I think for projects like this, we really need to be considerate of that timeline. Like, time is a colonial thing, because if we opened this up and we just had like unlimited and we'll just talk story, we would be here all day, but then we would have breaks, we would have food, we'll have laughter. It just, that's how we are back home. And then also, and I can see my table right here. I keep looking at the both of you for reassurance because yes, because, that's how it would be. But I guess that would just be a recommendation, is just thinking about the type of project you want to implement, thinking about the timeline it would be, and then also doing the most justice, because at the end of this research project, the results didn't they basically didn't affirm our hypothesis, which is basically that we need a new food insecurity screening tool. But from my own lived experience, I'm like, that is absolutely not true. There needs to be having more conversations with our elders who primarily use these services. A lot of us youth are told and to get a higher education to go to these large metropolitan areas, and when we do, we say we're going to come home, and actually we don't, and it's because either the resources or the workforce isn't there. And these are just such big conversations that need to be opened up in order to drive research, to drive resources back, to drive that data sovereignty and sustainability within tribal communities. And I'm just speaking from Navajo Nation because I am there and eventually I want to go back, but just kind of things to think about before I do that.
Thank you. Kelli, what would you like to add?
Well, I feel like I already had a bunch of recommendations already, but I just want to reiterate how important relationships are, regardless of your role. And so tribal communities, we've heard about how long things take. Part of that is building relationship, and it may not be, it may be years before you're actually accepted and working in these communities in whatever role you're working in them as. But if you are committed and dedicated to serving Native communities, expect that. Expect the long road ahead. And, I think time, again, is a colonial thing, and that, which is why we've taken all of our time and then some. Just kidding, right now. But just it's going to be a long journey, especially if you're not from that community. Even natives ourselves can't just go into any old community, in Native community, and say, hey, I'm here, I'm Native, let's do stuff. That doesn't happen that way either. So yeah, that would just be my last.
Yeah, and I think that is a common thread through everything that's been presented, is just not only the time for these projects, and that's kind of on the biggest scale, but then also the time taken by healthcare providers and the sensitivity and intention behind these questions and behind the programs that are put into place. With that, I want to just put up here our LinkedIn information if anybody would like to connect with us, though, T, I think you've already really networked the heck out of your presentation. And then I think pass it to Emily.
Elizabeth, how are we doing on time?
Yeah.
Okay, excellent. Well, thank you. Okay. Excellent. Thank each of you for this incredible conversation. I have so many ideas in my head right now from the insights that you all shared. Briefly, I'm Emily Jones. I'm a nurse and a researcher. I work at the University of Oklahoma. For over 15 years, I have had the distinct honor of partnering with tribal communities in Oklahoma and also in Massachusetts and Connecticut around women's health, and particularly maternity care, and also in this broader space of health promotion to prevent diabetes and prevent cardiac disease down the road. So right now, I think maybe the reason I'm here in this room is because I have the honor of co-leading with Mariana Wetherill a project that's focused on food security and social determinants of health and addressing those to improve maternal health and really reduce maternal morbidity and mortality. So one thing that stood out to me among all three of your talks and the insights that you shared is this focus on strengths-based approaches and seeing culture as protective. One thing we know when we think about food deserts, when we think about maternity care deserts, we know that access matters. We know that it's essential. It's the first step. But we also know that even when the resources are available, sometimes the barriers that are there, the nuanced barriers, really get in the way of people being able to access those resources. So my question to any of you, to all three of you, if we have time, is what are your thoughts from your experiences, from the relationships you've developed over the years and programs that you've designed and implemented? What are your takeaways for us around really always keeping this strengths-based lens and culture as protective focus at the center of what we do?
Yeah, go ahead.
I'm glad you asked that question. Somebody had asked, Cassandra had asked me, I'm interested in a PhD program. She was like, what would you study? I was like, something around social determinants of health. So back to Seven Directions. They're not even paying me to be here. I have no idea why I keep talking about them. Just love my work. I'm telling you, please fill out that feedback form. But at Seven Directions, I had the opportunity before funding ran out, and we had to essentially stop our work, is recreated a curriculum, and it's all centered around Indigenous social determinants of health, and it's looking at those protective factors. And we had the opportunity to present in DC, and basically what we did was we just talked about how these protective factors are super important, and a lot of it has to go back to like language and culture. As I mentioned, our team is very diverse, so we had different people talking about what those different things mean because they're very subjective. But really emphasizing, like, when we were growing up, these are just things we didn't have, things that we did, but also now that I'm thinking about it, it's also like what kept me safe. So I mentioned my grandma earlier. She's a primary figure that played a role in my life in raising me, because we're raised by so many different people in the household, not just mom and dad. And so with her, she would always tell me things like, you can't be outside at night, you can't do this, you can't do that, make sure you close the blinds and turn off the lights. And so these things, growing up, I was just like, grandma's telling me to do this again, and she would always say, like, if you do this, then this is going to happen. There's a term back in Navajo reservation, they say, iya, man. And I would always be like, oh my gosh, I don't want the man to get me. What man? I don't know. And so they would always say that. So that would keep me inside. Fast forward to when I was going to college, my grandma said that the words of advice were, don't go out at night when it's late because, of iya, man. And I just thought about it. And I was like, okay, like, I'm at a college institution. Everyone's out late at night. It's 3 a.m. Everyone's outside their dorm. Like, I don't know. And then, like, I would always think, like, no, I have to go back. My grandma doesn't know, so I need to go back to my dorm, be safe, get rested, whatever. And so now that I'm growing up, I'm like, oh, those are like protective factors for being an Indigenous woman in a city that's predominantly not Indigenous. And then we have higher rates if we know, like MMIW, MMIWP. And so those are just things that now I'm connecting the dots as I'm a researcher older. I'm like, oh, these teachings protected us. My grandma knew how to take care of me, like, decades later before I knew how to take care of myself. So in a nutshell, I think back to what your question is that, yes, that these factors, although we like to say like XYZ Native Americans suffer because of, these different social determinants of health, but also know like these other Indigenous protective factors have protected us from different either like substance use or either like violence and so forth. And I guess I'll end with that and maybe toss it to Kelli, because I think your brain, it looked like you had a thought.
No, I think that was great. Yeah, I would just say in practice to make sure you're looking at whatever story, whatever you're trying to say, and really taking a second to think, is this said in the most positive way it can be said? And so sometimes, because you're just used to just saying the same old thing or reusing content or what have you, but really stop and think and look at it through a different lens.
Well, thank you again to each of you for taking the time to travel here, taking the time to prepare for this incredible, cohesive presentation. Kelli, I can't help but think of your words earlier around that there's so much love that is poured into this work. And it's wonderful when your life's work aligns with what you love and care most deeply about. But I think that the meaningfulness of this work is only so much more palpable because of the love that you have poured into it. So thank you for doing that for your own communities and so many others. And thank you for sharing that with us so that we can learn.
And we have time for 1 or 2 questions from the audience.
That's fantastic. Are there any questions in the audience? If so, please use your microphone. And if you can't think of any now, I think our speakers will be around for a while, so please grab them. Thank you for your attention and again for this wonderful session.